historic moment, you know, for all of us when this MTP amendment came last year in 2021 and was implemented in October. And with that MTP amendment, there are many more things which we are going to talk about, you know. This MTP amendment, we had the MTP law way back in 71 when it was implemented for, you know, because they were unsafe abortion. Then in 2000, there was a time, then there was a lot of activity for safe abortions. And now in 2021, we are talking of respectful abortion care, you know, a new thing added to abortion. So this training, when we say respect, it is like respectful maternity care only. When we say respect, respect not only means that you're talking to the patient nicely. Respect also means that you are giving her whatever is best for her in the proper place by a proper person. They all are part of respectful. So this initiative by Dr. Shanta Kumari is really good, and in which, you know, she has, with WHO, she has partnered and to, you know, bring this respectful abortion care concept to everyone. Is my screen visible?
Yes, ma'am.
Yeah. So this is a FOXY WHO initiative of respectful abortion care.
Ma'am, the presentation is not visible.
Not?
It's just
No?
the
Ma'am,
folder
can
which
you
is
stop
visible.
your share screen, ma'am?
Yeah.
Just you click the share screen button.
Yeah.
After that, in the top, first one is the on screen. Just you click that one, ma'am. And then you click the share screen button.
Now you can see?
Yes, ma'am. And click that enable content is there, no? That one also you click, ma'am.
Ma'am, enable content.
Yeah. Now you can see?
Yes, ma'am. Yes.
So this is a FOXY WHO initiative in which it is the vision of our president that each Foxonian, all the 38,000, they should know the concept of respectful abortion care. And hundreds of us have been trained to do that. And this is our first program for Delhi. And this is being conducted by me, Dr. Achla Batra, and Dr. Monica, and Dr. Shivani. So we have, you know, 4 modules in it. One is medical termination of Pregnancy Amendment Act. We'll be talking in detail about it. And then, like so many people said, they want to know what is a safe abortion, how it can be performed. So Dr. Shivani will be talking about it. And then there's something, you know, which the WHO has taken up from the respectful maternity care, something like that as respectful abortion care. They have a SAVOR toolkit. SAY is an acronym. S is for say, safe abortion, you know, resources, and V is for, I'll just come to it. So we have with us Dr. Monica, who is a professor at VMCC and Subject Hospital. And she is the secretary of AOGD, and a very, very bright and academic and very active person with many awards. And we have with us Dr. Shivani Agarwal from Kasturba Hospital, who is very academically oriented. She's also the coordinating a PG forum, has got, you know, many honors from AOGD, NARCHI, and many medals and many publications. So we will be discussing with you, you know, the MTP amendment first. So I'll be talking about MTP. So what are we going to talk about? We are going to talk about what are the new laws and what are the new changes in it and how they are going to affect us. Why this amendment was needed? Because in India, still unsafe abortions, they lead to a lot of mortality and morbidity. And they are the third leading cause of maternal mortality. and 8% of maternal deaths are due to abortions. And 2 out of 3 abortions are unsafe. And these unsafe abortions are occurring in very young population, in women and girls under 24 years. So we don't want that. The World Health Organization says abortion is safe when it is done by an appropriate method, by a trained person in an appropriate place. If any one of the criteria is not met, then we call it unsafe abortion. And this has been mandated by the law. MTP law, like I said, came in 1971, but this 2022-21 amendment, how it is different. I think you're all aware what was the previous law, what were the indications for abortion in that. And so what are the changes I want to highlight? The previous act said that you require the opinion of one provider for MTP up to 12 weeks and 2 providers for MTP for 12 to 20 weeks. Now it has been changed. Now it is only one RMP for termination of pregnancy up to 20 weeks. And if it is beyond 20 to 24 weeks, then you require opinion of 2 RMPs. Why it was done? Because there are small nursing homes, there are places, then there it is not possible to have another doctor. So if you are trained in safe abortion provision, it has been now allowed that one can do MTP up to 20 weeks by signature of only one doctor. Then for beyond 20 weeks in the previous law, there was no provision for MTP unless it was for the saving the life of the woman. But now the upper limit has been enhanced to 24 weeks. This has been done because we have a special vulnerable group category of women like rape victims, minors, and many others, which we'll talk about, who miss out on that period of 20 weeks, and at 21 weeks, we tell them we can't help them. Another thing is there are many birth defects which are mostly detected very clearly only after 20 weeks. And some are, they become worse after 20 weeks. And then when you have a small defect, you think is going to be okay, but it worsens, then you have that window period of 4 weeks in which the MTP can be performed very easily just with the consent of opinion of 2 doctors without going to, court and all. Earlier, we had to go to court, and we've heard of so many cases. Nikita from Bombay, who ran from pillar to post to get a child which was malformed so much that it wouldn't have survived, but she really had to run. So that thing would be avoided. Then we have said that provision was only up to 20 weeks, and now this upper gestational leave has been changed, like we already talked about. And with even after 24 weeks, we can do medical termination of pregnancy when it is certified by a medical board that it is required for the health of the woman and it can be done safely. So what is the advantage of this? Like I already talked about that sometimes not only 20 weeks, there are pregnancies with such anomalies that beyond 24 weeks also, if they continue, the baby is not going to be viable, physically, or, is going to have such lethal anomaly that will not survive very long. And these patients would then, when they know they have such an anomaly, they will go anywhere to get the pregnancy terminated. Now we have a provision that if a medical mode is made, they can be allowed termination of pregnancy at any gestation. Then there used to be this condition of failure of contraception. This was only, for married women or failure by her husband. Now, this has gone beyond any woman or her partner. If they say they had failure of contraceptive, they can be given MTP. Because, this is being judgmental. When we say if she's only married, only then failure of contraceptive will apply, which is being, who are we to be judgmental? Who are we to decide that if she's not married, she cannot have an MT? So this condition of failure of contraception is now applicable to all women and their partners. So this will also further, decrease illegal abortion. It will provide increased access to safe and legal abortions, and increase access to safe abortions. Then the previous act said that the information should not be disclosed about the abortion to anybody unless it is for law. But now we have gone beyond that. We are gone beyond that to maintain the confidentiality of the woman. When in public sector, I think private also maybe, when a woman comes for MTP, she is given a number. And that number only is her identity. Her name is written nowhere except in the forms C and D, where it is mandatory that the names are written. But those forms are kept under lock and key. The register, their name is there, it is coded, and the register is also kept. So the confidentiality of the woman is totally maintained, and it is only revealed if it is authorized by law for any purpose. So this, gives them more autonomy, and they want to be private, they want to be confidential about, because they feel it is their right that they only should know and nobody else should know, and they feel it will affect their dignity if everybody knows she's admitted. Suppose an unmarried girl is admitted and people know she's unmarried, or so she will be, looked down upon. So we maintain confidentiality not only for those, for every woman who is coming for MTP, her confidentiality is now maintained. No names are written on the case sheets of MTP. So this ground of failure, this is a big step, prioritizing the confidentiality of the woman, and the failure of contraceptive being, extended to all women and their partners, and not just married women and their partners. So now we said that we can do MTP from 20 to 24 weeks in special or vulnerable category of women. So who are these women? We'll talk about. And who are the registered medical practitioners who can do MTP? We'll talk about that. And what is the power and the function of the medical board? So now the vulnerable category for whom MTP can be done with the opinion of 2 RMPs are those who are survivors of sexual assault, rape, or incest on humanitarian setting. Like if there is a drought, like we had COVID, people could not come for MTP because of that. So these situations are also coming under the purview of law, that these women can get MTP done. If a woman husband dies, she becomes a widow, or she is divorced and she doesn't want to continue pregnancy, this is one of the grounds. These was women with physical disabilities also, as per the Disability Act, they come under this preview, because sometimes these women are not able to come in time. Mentally ill women, including mental retardation, minors. Here, mind you, when we say minors, we have to be very careful that we cannot overrule the postcoitus. And if fetal abnormalities, they are so substantial that if the child was born, it would suffer from physical or mental abnormality, would be seriously handicapped. This is the 7th category. So these are the special people now for whom the MTP has been extended up to 24 weeks. Now, what are the RMP? RMP is MBBS, who has assisted in 25 cases of MTP, of which at least 5 are done independently. So that RMP is eligible. Somebody who has completed 6 months of house job in OBS and Gynae, who has a postgraduate degree or diploma in OBS Gynae, or somebody who has worked for 1 year in practice of obstetrics, and up to 20 weeks, like I said, only 1 RMP opinion. For 20 to 24 weeks, 2 RMP, and beyond 24 weeks, we have to have a medical board. Now we have another category of people who can do medical method of abortion, because like everybody was saying, they are medical method of abortions, they are very, very popular, very common, and everybody is using them. And it is not necessary to have extensive training for that. So we say for termination, because medical methods are allowed only till 9 weeks. So RMP with experience in the practice of OBS and gynae in any hospital for 3 months, or she has performed 10 cases of medical abortion methods under supervision of a RMP in a hospital, which is, or a nursing home, or a training institute which is approved for this purpose, they can perform medical method of abortion. And then this is a summary of this. Up to 9 weeks, we have two kind of experience. One, for medical method of abortion, in which 3 months or 10 cases is required. And for surgical methods, we required 25 cases, a postgraduate, or a 6 months house job, or a 1 year work in Department of Obs Gynae. For 12 weeks, we have same, a practitioner who has done 25 cases, 5 independently, postgraduate degree, 6 months of house job, or 1 year of practice in Obs and Gynae. For 12 to 20 weeks, we either a person who has a postgraduate degree, or somebody who has done 6 months of house job in Obs and Gynae, or who has been practicing in hospital for not less than. The criteria of 25 MTPs does not is not here. For beyond 20 weeks, we have to have a postgraduate who, again, 6 months of house job or at least 1 year. And here you require the opinion of 2 RMPs. Beyond 24 weeks, we can only get it done by a postgraduate degree or diploma holder, or somebody who's worked for 1 year, but only after a medical board has been constituted and medical board has decided that medical termination of pregnancy is required and it can be done safely, and it has to be done only then in an approved place for pregnancies beyond 24 weeks. Now, what is a medical board? A medical board, there are about 178 medical boards all over India. In Delhi, I know of, in LNGP, there's one, but state government is going to form many more medical boards, and Fox is also going to help it. Basically, the minimum requirement of a medical board is a gynecologist, a pediatrician, a radiologist, or a sonographer. And it is suggested that wherever this MTP occurs, the HOD gynae of that place should be the chairperson. It's just a suggestion. There should be a female, doctor in this board. And besides pediatrician and radiologist, if opinion of somebody else is required, maybe it is a cardiac anomaly or a neurological anomaly, then opinion of that specialty should also be taken, whether this pregnancy is compatible with life or not. And sometimes, one person who is part of the board goes out, is not well. So there is a suggestion that there should be provision for changing and not waiting for that person only for, doing. And what are the powers of this medical board? This medical board would be applied to for termination of pregnancy beyond 24 weeks. They would decide that, is it really required? Is it safe? And like I said, the baby would, if born, would be have substantial risk of being incompatible with their life or suffer from physical or mental abnormality to be severely handicapped. And they can co-opt other specialists besides the 3 mentioned. And FOXI with ministry and WHO support is trying, to asking the states to form more boards and put this information on the website, though it is still not there, so that anybody who wants, has a patient beyond 24 weeks whom they think requires medical termination of pregnancy, they can approach that board. So what are the functions of this board? They will examine the woman and her report, would approach them and provide their opinion in Form D with regard to accepting or rejecting their request for termination, and they have to do it within 3 days of receiving that. And after that, once they decide that pregnancy has to be terminated, then within 5 days, the pregnancy has to be terminated after appropriate counseling. So this is all about amendments of the law which are there. And I will request you, when we finish, you must do the post-test and the feedback if you want to get the certificate, because without the post-test, we will not get. And now we go on to, and any questions, if they are there, maybe we can take them all together, or if anybody feels that, they want to right now ask something, they can put it in the chat box and we will see what is to be done. So, Monica, can you see anything in chat box?
Not right now, ma'am.
No? There's nothing in the chat box at the moment?
No.
Okay. So, good afternoon, Dr. Ajay. Good to see you. So now we go on to the next part of the module, for which everybody was asking, as I was asking you earlier, that how to provide the safe abortion, what are the methods, how ideally they should be used. And we have Dr. Shivani with us, who is going to talk about it. I already introduced to you all Dr. Shivani. So Dr. Shivani, please take over.
Yes, ma'am. Yes. I'll share my screen. Is it visible?
Visible. Yes.
Is it visible?
Yes, Shivani, it is.
Okay. So good afternoon, everyone. At the outset, I would like to thank Dr. Achla ma'am and Dr. Monica for permitting me to speak on this platform. It is updates in technology of safe abortion. Why are the slides not moving? Slides are not moving.
You can stop sharing and reshare. And Monica, meanwhile, she's doing it. I think I saw some questions in the chat box. Can you ask?
No, now it is. Yeah. Now it has come back.
Yeah. Monica?
So in this session,
No, Shivani, your slides are still not there. While you do it, there are 2-3 questions we can handle. Monica, can you?
Yes, ma'am.
Ask me those questions,
Yeah, first one is, can we do MTP from 15 weeks as failure of contraception?
Up to 20 weeks, all the indications which are there, they are, one RMP can do it.
And then what are the guidelines for filling forms for abortion by pills?
Is the same. There's no difference in the filling form. The forms have to be filled as we do it for surgical abortion.
And then a very common query which we have all faced again and again, how do we ensure confidentiality when we have to inform hospital, and how should we do that without telling the patient's name?
See, like we do in our hospital, when a patient comes asking for MTP, we are giving her an MTP number. And then we are asking for her to get her paper made with that number, not with her name, but just that number. So that way we are maintaining the confidentiality, but all the forms, they have to be filled with names, and we keep them in lock and key, and they are not available to anybody except the person who, if by law we are asked to do it.
Dr. Deepa has asked, can anything be done to stop chemists not to dispense abortion pills without
Government can do it,
prescription?
we can't.
Wishful thinking.
There's
Yeah.
another thing, I don't know somehow where did that slide go, that when a minor comes for this thing, MTP, then the consent can be given by anybody who is more than 18 and is accompanying her. It need not be her relative, mother, or guardian. Anybody who is accompanying, is more than 18, is willing to give the consent, can give the consent. Shivani, are you comfortable? Monica, any more questions?
Even the
two more
boyfriend
we'll
comes
take
with the
later.
patient?
Maybe Dr.
Yeah, if
Shivani
he is
can
more
continue.
than 18 and is willing to take responsibility, yes.
Then there's no need to inform the parents or inform the police. No.
If the girl is more than 18, you don't have to inform the
No,
police.
if a girl is minor and the boyfriend who came with the patient, who is that?
See, do not mix the POXO Act with MTP. We have
Okay.
to go by that act, that anybody under 18, you have to inform the police, otherwise you would be in trouble. But it is not necessary that we have to inform her parents, but the police has to be informed, because that is the law.
And that is just for our knowledge only.
Yeah. After
We
that,
won't
we
The
will
rest of the
see.
queries, ma'am, we can take later once Dr. Shivani finishes.
Yeah, unless there is something really pressing,
Ma'am,
we can take it
in
later.
case of married woman, if husband is not willing to give the, I mean, he wants to
Husband consent is not required. Husband consent is not. Woman is an autonomous person in her own right. And
Okay.
It does not require the consent of mother-in-law or husband.
He wants to continue the pregnancy. If she don't want to continue, then
No, it is the woman's wish. It's her body.
wish.
Yeah.
Okay. Thanks.
Yeah. Achla, thank you so much, and Shivani and Monica, for taking this process forward. Good afternoon, everyone. Sorry for half a second of butting in.
Yeah,
Please
sure.
do carry
Sure,
on
sure,
with this
sure.
wonderful presentation and the question answer session. I can see a lot of excitement and a lot of questions and doubts which are being clarified. And I'm supremely confident that all of them will be answered at the end of the session or at the end of each topic, as and how Achla would like to take it forward. I just would like to leave you with one thing. At the end of the session, please do submit the post test and the feedback, because that is important for ensuring that you get your certificate. And also, when you leave the meeting today, at the end of the training, a pop-up should come, which will tell you to continue or exit Zoom. Please click on continue so that you are having access to it. And for any reason you're not able to have an access to the post test and feedback link, Achla here or my backend team will post that in the chat box for you to copy. So Achla, I've already sent it to you one-on-one. Before the end of the session, please do post it here in the chat box for everybody to directly click and submit that. Okay, that all the very best. Please carry on. Hope to see you in person sometime soon.
Yeah.
Thank you. Thank you.
Yeah.
Mr.
Thank you
Ajay.
for coming.
Thank you.
Programs. Bye-bye.
Thank you. Bye.
Okay,
Yes,
so-
Shivani.
Yes, are my slides visible?
Yeah.
Okay, so I will continue. So in this session, we would be discussing about the existing guidelines, the pre-abortion assessment, the medical methods of abortion, and the surgical methods of abortion. Now, as we can see here, this is a list of manuals by WHO, all about safe abortions, technical and policy guidance, medical management of abortions, and medical abortion commodities. And in 2019, there is a consolidated guideline on self-care intervention for health. And just now, Dr. Achla ma'am has talked about the historic medical termination of pregnancy amendment 2021 by the Ministry of Health and Family Welfare. So all the guidelines have three key areas in the management of abortion safely: pre-abortion care and counseling, abortion care methods available to us, aftercare and follow-up, which includes the post-abortion contraception and counseling. So for counseling, I would like to say that while counseling, confidentiality, privacy, and respect needs to be maintained, it needs to be done by a trained person in a conducive environment where thoughts, feelings, and perceptions can be shared openly. So coming to the pre-abortion assessment and counseling, what has to be done? What are the points to be covered? A detailed history, which includes mainly the period of amenorrhea, the signs of ongoing pregnancy like nausea, vomiting, breast tenderness, frequency of urination, etc. The detailed obs and gynae history, the bleeding tendencies and medications taken by the patient currently, and so on. In a general physical examination, we of course examine the patient as a whole, and in the pelvic examination, please mute yourself, everyone. And in the pelvic examination, we'll be talking later, the laboratory and other investigations, decision making, information on abortion procedures, and counseling. So in the pelvic examination, the abdominal examination, we all know as gynecologists, we have to assess the size of the uterus, but sometimes there are limitations to dating by uterine size on physical examination, like uterine malformations, fibroids, twin pregnancies, marked uterine retroversions, obesity, and molar pregnancy. Now, this is definitely an update that in the pre-abortion investigations routinely are not a prerequisite now. But anyhow, it is more clinician-centric and provider-centric, that the tests can be performed as per the individual risk factors on the findings of the physical examination. Like if the treating physician feels that the pregnancy is not confirmed, they can do a pregnancy test. If they suspect anemia, and hemoglobin or hematocrit can be done. RH testing, HIV testing, since the patient has come to us, so she can be tested for that also. Then STI screening, usually performed during the pelvic examination, and other laboratory tests as indicated by the medical history, like the kidney or liver function tests. Ultrasound is not necessary unless to diagnose a pregnancy where we suspect ectopic pregnancy or missed abortions. Now, what about pre-abortion counseling? What we have to ask certain things and we have to inform certain things. Now, what have we to ask the patient? We have to ask the thoughts that are coming to her about the termination of pregnancy, like what will be done to her during the operation procedure, or what would be the time taken, will she have pain, will she have bleeding, and so on. So many questions. And then the reasons for termination. Maybe she is under pressure of family or peer pressure or whatever. And then what has to be informed to the patient? That early abortion is always safe. There should be a trained provider doing this process. What are the available methods of abortion, and help her in decision making, the risk and warning signs of each method. Without contraception, she can get pregnant again after 14 days, as less as 14 days of abortion. When can she resume her normal activities, her normal sexual activities, any other follow-up care that is required. And regarding the documentation, there should be an informed written consent. And as Dr. Ashla just said, that an adult woman is an autonomous person. There is no third-party authorization required for the consent purposes. Then decision to accept post-abortion contraception. Even if she is not willing for contraception, she should be provided the abortion services. Then abortion care can be divided into less than 12 weeks and greater than 12 weeks. In less than 12 weeks, we have the medical methods and the vacuum aspiration. So in the medical methods, we have the combination regimen of Mephibostone and Misoprostol, or we can give Misoprostol only. In greater than 12 weeks, again, we have the combined regimen, the Misoprostol only, and dilatation and evacuation. Dilatation and sharp curettage is not recommended during pregnancy. So what are the methods available to us in the first trimester? Medical methods and manual vacuum aspiration and electric vacuum aspiration. Now coming to the Mephibostone, what is the mode of action? It is an antiprogestin. It inhibits action of progesterone and interferes with the continuation of pregnancy. While Misoprostol is a prostaglandin E1 analog, it causes cervical softening, uterine contractions, and expulsion of the products of conception. Now, what are the advantages of Misoprostol? It is low in cost, it is easily available, it does not require refrigeration, and it has a long shelf life. Now, what are the protocols for Mephibostone, the combined regimen? On day 1, we give Mephibostone 200 milligram. It is always oral, always the oral route. Then if the woman is Rh negative, we can give her anti-D 50 microgram if available. And on day 3, we call the patient again and we give her Misoprostol as recommended by the WHO. It is 800 microgram, either sublingually, buccally, or vaginally. In addition, for supportive measures, we can give analgesics, antiemetics, and we can offer her contraceptive advice and contraceptive services on day 3 itself. Then on day 15, that is the follow-up day, we confirm and ensure the completion of the procedure, offer contraception if not already done earlier. Then what are the various routes of administration of Misoprostol? It could be orally, buccally, sublingually, and vaginally. Now in the buccal and sublingual route, in the buccal, we place the tablets between the cheek and the gums, and sublingually, we place it beneath the tongue, and it can be swallowed after 30 minutes by the patient. Then vaginally, we place the tablets in the deepest part of the vaginal fornices, and the patient is instructed to lie down for 30 minutes. The vaginal route has the lowest rate of side effects. This is a diagram showing the buccal and the sublingual route. As I said earlier, in less than 12 weeks, we give the 200 milligram Mephibostone and 800 microgram buccally, per vaginally, or sublingually Misoprostol. We can also give Misoprostol alone as an alternative regimen. In that case, we give 800 microgram buccally, per vaginally, or sublingually. The patient has to be explained that the vaginal bleeding may continue for 2 weeks, or in some cases, it may continue for 45 days. Now, where should these services be available? They should be available at the primary care level with referral systems in place for all required higher level care. Additional services may also be provided to the patient. Since the woman is coming to us, she can be helped in that case, like psychological or social services, counseling for HIV, STI, providing her iron tablets for anemia, or providing necessary pain medications, providing emotional support, and also providing sanitary napkins. Then follow-up care, routine follow-up is not necessary following an uncomplicated medical abortion using the combined regimen. However, if the woman insists, then she can come for follow-up at 7 to 14 days so that the contraceptive counseling can be again reiterated if not done earlier, and for emotional support or address any other medical concerns. However, in the Misoprostol only regimen, a routine follow-up after 15 days is a must to assess the success of the abortion. So in the follow-up care, we assess the woman's recovery and ask for signs and symptoms of ongoing pregnancy, review any available medical records, the MMA card that is given to her to fill up. We can also review that, ask about any symptoms experienced since the procedure, perform a focused physical examination for any complaints that she has, or assess the women's fertility goals and need for contraceptive services if not provided earlier. So to summarize, What do we do with the MMA? Physical and pelvic examination confirm the eligibility of the woman for this process. Then tablet Mephibostone on day 1, anti-D if the woman is Rh negative on the same day. Then the woman is asked to come for Misoprostol on the 3rd day. The, the patient should be given the contact address and phone number of the facility where she can go in cases of any emergency. She should record her experience on the MMA card. Now, 3% of women may expel completely with Mephibostone alone, but Misoprostol schedule should be completed always. Now, on day 3, she is given Misoprostol. You observe her for 4 hours. Usually, the bleeding and the cramping, they start after 2 to 3 hours of Misoprostol. We give her analgesics and we offer contraceptives. We tell the woman that the bleeding can continue for 8 to 13 days. There can be possible side effects like nausea, vomiting, diarrhea, etc. She has to report in cases of excessive bleeding. Now, this is very important. She should know when she has to report to the facility. So report in cases of excessive bleeding, pain, abdomen, and fever. Report if there is no bleeding 24 hours after Misoprostol. Then 75% of women can abort within 4 to 6 hours after Misoprostol administration. Now, what to do on day 15? A pelvic examination to ensure the completeness of the procedure. Contraceptive options if not given earlier. Sterilization should be done after 1 normal menstrual cycle. Now, we have to tell the women about immediate return to fertility. She has to report back if there are no periods within 6 weeks of completion of the abortion process. USG only if examination does not confirm the completion of the procedure. I think this is very important because we all try to get repeated ultrasounds. Up kar lo, we can do another ultrasound, we can do another just to see the RPOCs. No, we should be more, the guidelines are also stating we should be more clinician centric. And if we feel that the abortion is complete by the pelvic examination, then ultrasound is not indicated. Then how to manage the complications? Pain, of course, there is verbal support and there are the NSAIDs, and then nausea and vomiting, diarrhea, they are all self-limiting. So we have to reassure the patient. Then infections, we have to confirm by physical examination and start the antibiotics. Now, if there is a failure of MMA methods, then we have 2 options, either offer vacuum aspiration or repeat MMA. If there are incomplete results of MMA, then we observe. Unless the bleeding is heavy, we have to wait and watch, and the bleeding, if it resolves and the abortion is complete, we have to do nothing. But if, however, the bleeding continues, then we have to offer her surgical evacuation. Now, what to do in cases of excessive bleeding? Now, what would be the excessive bleeding? If the bleeding is more than her menstrual cycle, or she's soaking 2 pads in 1 hour for 2 consecutive hours. So in that case, we have to admit the patient, we have to observe the patient, we watch for vital signs, we do a pervaginal examination, and we do a digital evacuation if the POCs are felt in the cervical canal. And if the woman is stable and the bleeding reduces, then we can observe and monitor. But if the bleeding continues, then an ultrasound is indicated. If the minimum decidual bits, wait and watch. If there are POCs and decidual bits and the woman is stable, we can offer her Misoprostol 600 microgram orally or 400 micrograms sublingually. Or if the woman is not stable, we can give her vacuum aspiration. If there is continuation of pregnancy, then of course we have to offer her vacuum aspiration. Now, this is very important that MMA also comes in the purview of the MTP Act, and the documentation is similar to that required for the vacuum aspiration procedure. So it is mandatory to fill Form C, Form 1, that is the RMP opinion form, Form 2, monthly reporting form, and Form 3, admission register for case records. Now, what are the surgical methods of abortion available to us? So there is the manual vacuum aspiration and the electric vacuum aspiration. Now, WHO recommends manual vacuum aspiration as the safest method. The procedure, as I already said, should not be completed by sharp curettage. Now, this is a diagram of the handheld portable vacuum aspirator. Now, this diagram is we have already all I
जब
think
से आई हूँ तब से सिर्फ सामान उठा के ठीक करने में लगी हुई हूँ
we
पूरे
have
घर में ऐसा फैला
Requesting
के रखा है।
everybody to please mute themselves.
Dr.
Dr.
Amita,
Amita, please mute yourself.
So this diagram is self-explanatory. Here we have a cylinder base, a collar stop, and a retaining clip. So that and there is a plunger with the plunger arms, and then we have we have the valve and two valve buttons. There is a cap and cap release tabs, and at the apex we can put the cannulas of the corresponding size, that is 8 mm cannula for 8 weeks gestation and 10 mm cannula for 10 weeks and so on. Now, this is the electric vacuum suction, which consists of a motor or an electric pump used to generate vacuum. Then there's a vacuum gauge. Then there are two glass jars for accommodating the products of conception. Then cervical priming. It may be considered for women with a pregnancy of any gestational age to prepare the cervix, and it makes it soft and easy to dilate. So what are the recommended methods for cervical preparation in the first trimester? Oral Mephibostone 200 milligram, 24 to 48 hours earlier. Misoprostol 400 microgram, either sublingually or vaginally, 3 hours prior to the procedure. Or laminaria placed intracervically 6 to 24 hours prior to the procedure. Now, pain management, we can do non-pharmacological management or pharmacological using medications. So non-pharmacological, we all know, providing psychological support, explaining each step to the woman in advance, performing the procedure gently, encouraging the woman to relax and breathe deeply. And what are the pharmacological methods? If the woman is anxious, we can offer a diazepam 10 milligram orally 1 hour prior to the procedure. For cervical dilatation, we can give paracervical block and of course NSAIDs. Then for uterine cramping, again, ibuprofen. So now what are the steps of manual vacuum aspiration? So as we can see here in the diagram, we close the valve buttons. We create a vacuum by pushing the plunger out of the cylinder. And then we ensure pain control medication is given at the appropriate time and ask the woman to empty her bladder. Then we perform cervical antiseptic preparation, administer paracervical block at 4 and 8 o'clock position, dilate the cervix, insert the cannula, and the cannula is inserted 1 to 2 centimeter away from the fundus inside the uterine cavity. And we rotate the cannula from 10 to 2 o'clock position. Then we release the buttons to release the vacuum. And then the products of conception, we can, this is the advantage of vacuum aspiration, that we can inspect the tissue. By inspecting the tissue, we can know that that it is, whether it is corresponding to the period of gestation or not, or whether if there is no tissue, then maybe our diagnosis is wrong, it is an ectopic pregnancy and so on. Then proceed with contraception methods like IUCD or sterilization. And then of course, instrument processing, cleaning the instruments with chlorine solution. So how do we know that the uterus is empty? Red or pink foam without the tissue passing through the cannula, gritty sensation over the surface of the uterus, cervix gripping over the cannula, uterus contracting around the cannula, and increased uterine cramping. So post-procedure care, we monitor her for any complications and provide management as needed. She may leave the facility when she is stable and meets the criteria for discharge. Ensure that the woman has all necessary information and medications prior to leaving the facility. Document all outcomes of the treatment, including any adverse events, in the facility register and the client's record card. So what do we have to do in the aftercare? Management of abortion complications. And what are those? Incomplete abortions, infections, bleeding, ongoing pregnancy. Provision of contraceptive services have to be reiterated again if not offered earlier. Assessment of any other sexual and reproductive health needs that may be required by the woman. So in the follow-up, no routine follow-up unless the regimen that we have given is Misoprostol alone, provided the medical abortion is uncomplicated. So to summarize, India has made historic progress in improving access to safe abortion. Not much has changed in technological update in the last decade. As providers, it is up to us to ensure safety and quality, especially in context of the amended law. Along with safety, we also need to focus on respectful abortion services. Every client, public or private, has the right to be informed properly, to be educated, and to be equipped with proper information on contraception and counseling. Thank you. So I pause sharing.
After we finish the full training, you must fill up the post-test and feedback form. And I think I saw some questions in the chat box while, Monica, while I, make preparation for sharing my slide, you can ask these questions to Shivani.
Yes, ma'am. I'll take up pertaining to her presentation first. Dr. Shivani, people have asked, please elaborate about medical abortion forms. Are they same as those for surgical abortion?
Medical abortion forms.
Shivani, stop share.
1 minute. Pause share. Screen sharing, stop share. So regarding the MTP forms for medical abortions, the forms, as I said in my presentation also, that they are exactly the same as required for vacuum aspiration, Form C, form the RMP form, and Form 2 and Form 3. They are all exactly the same as the vacuum aspiration. There is no difference in the forms. We should not give the phone pe bol diya, haan bhai theek hai ye lena. No, if the patient is coming for medical methods of abortion, she has to, all the forms have to be completed as we do in cases of vacuum aspiration.
Okay, before giving the medical bills, is ultrasound necessary to rule out ectopic, or is ultrasound necessary
no,
to
as I
confirm
said,
completion?
yes, as I said, that now the newer guidelines by WHO, the handbook which has been released in 2018, it is more clinician centric, it is more provider centric. And if the services have to be given at the PHC level, and so ultrasound is not necessary. It is only to be done if the provider feels that it is necessary and he or she feels that ectopic pregnancy or missed abortion or whatever has to be ruled out.
Any more questions, Monica?
Repeat dose of meso if no bleeding has occurred in 24 hours.
Yes, definitely additional doses of Misoprostol can be given. And in the newer guidelines, there has been no upper boundary that these many doses are to be given, 3 doses or 4 doses. It also has been left to the clinician to decide how many doses to give if additional doses are required.
Okay, and I think this is anyways clear, but for the sake of all the audience, I'll take this question. Does NTD need to be given if pregnancy is aborted less than 7 weeks?
Actually, anti-D, I have already mentioned that while giving Mephibostone, we can offer her anti-D, but still it has been mentioned in the MOHFW guidelines that at less than 7 weeks, if the anti-D is not available, then usually the women do not, if they are RH negative, they would not be there likely chances that they won't be sensitized by this pregnancy. So if it is not available, then
Unless
Ma'am,
surgical methods are used,
Yeah,
if medical method, no intervention, then, yeah.
if it is available, we can give. If it is not available, then okay.
okay, and method of choice between 9 to 15 weeks, surgical or medical?
Now, this has to be decided as a whole by looking at the patient as a whole. We can't say which method. We have to offer the choice. We have to tell them the methods available to us, and then we have to really decide which method would be safe for her.
Okay, so Achla ma'am, actually there are many questions for you as well. So would you like to take them now or after your second presentation?
You
I think
decide
they are
if they,
pertaining to first module. I think we should take them up
okay,
because they will probably keep lingering on in the minds.
yeah.
So
अच्छा ये बताओ,
maybe-
my slide is visible ना?
no, your folder is visible right now.
Okay, फिर कुछ गड़बड़ है, मैं इसको ठीक कर दूं, उसके बाद फिर हम करते हैं. So
हाँ,
I start
till
Bashir,
that-
I start screen sharing, then I go click this, then I share. Now
Yes, ma'am.
now there
it's
is,
okay.
yeah.
Yes,
बताओ,
ma'am.
question बताओ.
Make it slideshow, ma'am.
हाँ, that I'll do when we start. Yeah.
Okay, ma'am.
So ma'am, question is confidentiality is required only for MLC plus MTP or
No,
all MTPs?
all MTPs, all.
Ma'am, your connection is probably problematic. I think Dr. Achla has lost the internet connection. Till the time she joins back, maybe Dr. Shivani, you can take one or two questions.
Yes.
For especially the private practitioners have asked, in private practice, is a number required to be informed to the associated hospital? And those who are working in private clinics, how to give the number?
For referral for higher centers?
No, for the sake of maintaining confidentiality.
They can always talk to their administration, and they can provide an MTP number. It has to be done. It has to be done in coordination with the hospital, with their administration. If it is a private clinic,
yeah.
If it is a private clinic, then they have to. I mean, this is a requirement now. And rather in Kerala, I know that if you if you show the name of the patient to anyone without, I mean, if it is not asked legally, then it is a crime. So we have to do it in any way.
So in this regard, even I would like to elaborate one thing is that, see, maintaining confidentiality means when you are suppose admitting the patient or otherwise, giving some kind of document to the patient in which her name is otherwise required had it not been MTP. At that place, a MTP number is to be given, or in case it is an MLC number is to be jotted down. But at the same time, you have to make sure that for the sake of, for example, sexual assault survivor, in case MLC has been made, you have to follow all the directions which are there given as a medical legal examination of a survivor or under POXO Act, because that is governed by law itself. And any kind of formality which pertains to POXO Act need to be followed. It's just the documentation, the case sheet, the discharge slip, the papers which need to be given to the patient. Maybe they can carry the MTP number or the MLC number only. Rest all the places which is say a police document, MTP register which needs to be maintained, or any kind of documentation otherwise which is required, which is information to police, because it is again governed by law. All those places you have to follow rules as per the guidelines. Like there you can mention the name, but all the documents which will be given to the patient or maybe the relatives around, or people around who have access to those documentation, there only a number needs to be maintained, because confidentiality is for public. But all the authorities which are governed by law, wherever all those formalities are required, they need to be followed. So we need to really very clearly understand that MTP Act and POXO Act, they are two different entities, and all the things which are mentioned and within those frame lines have to be followed separately.
Yeah, I'm sorry, my connection got lost in between, but I hope you continued with the questions.
Yes.
Yeah, we took a few questions, ma'am. So then to continue, in case of MTP with the sterilization, again, the same thing, whether the form with name or case sheet or discharge paper, I think this I have clearly explained already. If the abortion is done after 24 weeks and also permitted by the board, is an autopsy necessary to prove it, maybe the reason for abortion?
No, it is, this is now a medical termination beyond 24 weeks. Everything has to be cleared beforehand. After we have performed the medical termination, autopsy, if required, would be done because the patient wants to know the cause, then only. Otherwise, not for the purpose of proving to law that this was okay.
Failure of contraception as a cause for MTP, can we do that till 20 weeks?
Yeah, we can.
Yes.
Okay, so I guess still, okay, again, I think Dr. Seema, your query is solved now, how to maintain privacy in discharge card and admission slip.
Yes, thank you.
Do
Thank you so
you,
much.
okay. So do you have to do ultrasound after 2 weeks to confirm complete abortion? I think Dr. Shivani has answered that very clearly. Method of choice also answered. Please explain other methods of abortion after 12 weeks to 20 weeks, other than medical. Dr. Shivani?
Other than medical, see, I have already elaborated that at greater than 12 weeks, we have the medical methods, the combined regimen, the Misoprostol alone, and dilatation and evacuation. So these are the three methods. Now we have to judge which method would be suitable for the patient at regarding her gestation, seeing her gestation, and other medical conditions. So we have to, these are the methods available to us.
So taking the ultrasound thing forward, somebody has asked, nowadays in private sector, everyone prefers ultrasound guided DNC. Is it necessary to do ultrasound guided?
See,
No.
it is not recommended in the guidelines. You can do whatever you want, but it is not there in the guidelines.
I guess it's all about catering to patients' choices, but as such, under respectful abortion care, per se, ultrasound has not been recommended as a guiding tool.
Yeah.
So I guess, ma'am, till now we have taken all the queries. So Dr. Achla, you can carry forward.
I'm sorry to interrupt. And the dose of Mephibostone depends upon the period of gestation or not?
Yeah, definitely.
Yes.
Like in greater than 12 weeks, as recommended by WHO, it is 400 microgram. After Mephibostone, 200 milligram, 400 microgram for every 3 hours.
No, I am asking about the Mephibostone dose.
Mephibostone is same, 200 milligram. Yes.
Irrespective of gestational period.
Yes, yes, yes.
Ah.
Mephibostone is same.
Thank you.
So is my screen visible?
Ma'am, it is,
No,
but
ma'am.
if you had opened the module already, ma'am, please open it from there.
Okay, I'll do that. Module 3. It is visible? Is it
Go
visible?
to the Zoom.
No.
No, ma'am, go to the Zoom
No, it is
portal
not.
and click share screen again.
I'll do that. Now?
Yes, ma'am.
Okay. So this is a very important module, you know. This is the crux of respectful abortion care. WHO has come up with the SAVOR module, Safe Abortion, Values, Evidence, Rights, and Respect. And this is, you know, there's nothing like this ever taught to us, you know. Even the respectful maternity care was not taught to us. And on the same lines, WHO has made this module. And this is not for the patient, it is for the doctors to how to change their attitude, the way they behave, not, you know, consciously, but these are the norms which are, you know, inbuilt in our society. There are some stigmas which we automatically think that this thing is wrong, you know. So this is to change our attitude so that any woman who comes to us for abortion is given, you know, respect, dignity, autonomy, and not, you know, like it happens not in private because there the patient is paying, but in public sector, a lot of time, if a woman is coming, you know, for multiple times for abortion, she is scolded, you know, and if an unmarried girl is coming, she's looked down about because these are the stigmas which we. So this module aims to define the respectful abortion care as WHO standards. It will also highlight how norms and stigmas affect the services, like I already mentioned. And also, it will provide WHO SAVOR resources for respectful abortion care. So what has happened now? In our country, we are, you know, probably on top of the world in having such liberal MDP laws. With new amendment, it has become or more liberal, but the onus is on us, the providers, to also provide comprehensive, safe, and respectful abortion care. And we, Foxinians, 38,000, we are the largest provider for the abortion care. And we can now, you know, train everybody. Like I got trained, I'm training 65 of you, and that way there are about 300 people. So, and these, we have somebody from Calcutta also. These webinars are become, you know, a way in which we can, you know, train sitting at one place, training. It was not possible to do it physically. And especially we have this medical method of abortions. A lot of people, because it is very simple and safe, and but we should remember that we should not be having any conflict with the PCP entity with it. All the forms need to be filled. And also patience, safety, respect, and quality of care matters more than ever, because now we have a single doctor up to 20 weeks who is responsible for all the woman's care for her abortion. So that doctor should know that how it has to be. So WHO says that respectful abortion care is care that maintains safety and dignity. Safety, we've talked about, Shivani told us the methods which should be used. Dignity by maintaining confidentiality, and freedom from harm. We should not be mistreating her, and also giving her informed choice that what is possible for her. Like so many people ask, what method after 12 weeks? So we have many methods. We explain to the woman what are the method, what are the, you know, pros and cons of the method. And also, not only she has to be given informed choice of using contraception after the MTP, and so that she doesn't need to have an unintended pregnancy. And we have to provide her support during MTP and even after MTP. This is the concept of respectful abortion care. In simpler, suppose you are a provider, you can also be a seeker once. So you would like to be treated with dignity, empathy, and compassion, whatever may be your race, gender, ethnicity, socioeconomic status, or whatever may be your history of multiple pregnancy, getting termination, or you being married, unmarried. And if at all, when these things are not provided to you as a provider or as a patient, when you're not getting respect, you have to speak up. So respect begets respect, and for that, communication is the key. So this is, we were talking about that we are governed by norms and we are governed by some stigma. So what are these? What are norms and stigmas? This is a small video which is a part of the Saver
Social
tool.
norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors, like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others personally and professionally.
So you all heard what are norms and stigmas.
Social
And-
norms are the
So these norms, in our private life, also in our professional life, somehow they do affect how we behave with the patient, how we provide services. And this SAVOR module of WHO has quite a few hours given to these norms and stigmas, in which, each norm, each stigma is discussed in detail, so that the bias of the service provider is changed. There are always two sides of a coin. We should not be going by whatever is norm is right. So this is what is the attitude changing which WHO is trying to do. And what do these norms and stigma do? That they perpetuate disrespect and abuse. And the categories of disrespect, have been defined by WHO. Physical abuse, we all know. Maybe in public hospitals, we have seen, sometimes in labor room, patients are, physically also abused, or if not abused actually by touching, but intimidating them does happen. Verbal abuse, very common, because shout, you scream, you tell them, why didn't you take care? Why didn't you take contraception? Why you keep coming again? You're not married, you have no morality. All this is verbal abuse. Sexual abuse, we know this is the abuse of power, taking advantage. And stigma and discrimination, we just showed you how the stigma affects. And this point 5, 6, or 7, the failure to meet the professional standard of care, poor rapport between woman and provider, and the condition of the health system and constraint, they all also have to be maintained. When we talk to a woman, we should give her time, we should be able to communicate with her, we should listen to her, we should provide advice to her and give her the choices and have a very good rapport with her. And the condition under which we are providing services also should be optimal. And because it is the right of every woman to be free from harm and ill treatment. And she has right to information, she has a right for protection, informed, acceptance or refusal. She has her preference. She has to have dignity and quality care. So the timely health care should be given to them at the best possible manner, without forcing them, without disrespecting them. This is what we aim to do by, going away from stigmas and normal norms which are there. So how do we provide respectful abortion care? That's, I mentioned earlier, it's not only talking to a woman sweetly and then you are providing respect. She has to be free from harm also. She has to be provided abortion safely. She should not be mistreated. Privacy and confidentiality, we already talked about. Maintaining her dignity, respecting her choice, effective communication, providing information and seeking informed consent, continuous access to support, not only during abortion, after abortion. And also quality of physical environment should also be good. She should be provided equitable abortion care. Competent and motivated professionals should be there to provide care. She should be provided with contraceptive advice, and continuity of care and counseling, again, after abortion, is very important. These 12 domains of respective abortion care, if maintained, will provide woman with good care, and she will come back to you again without feeling, apprehensive that she would be shouted at or she would be disrespected. So it is time that we strengthen our implementation. How? By providing respectful care. And we know single provider has to do it. So up to 20 weeks is all in your hand, and you only have to do the counseling for contraception, referral, and have to provide the compassionate care. After 24 weeks, we have a special need for these women. They have to be very sensitively treated and should not be judgmental to them, because these are the women probably rape victims or widows or who have, got a divorce. And besides the other medical indications, so we have to be judgment free. And of course, the confidentiality has to be prioritized. That is very, very important. So there's another video on a guide to avoiding stigmatizing languages. You may not think that you are using a stigmatizing language, but sometimes...
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well-founded. For example, sex-selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework, but may be safe if performed by a trained provider or when a person has access to high-quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 Ps, provider, place, and process, are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant.
There is, I think, a very good...
How to talk about abortion, a guide.
I think that was a very good video telling about, the language which we commonly also use. So we have to be careful when we are using what words we are choosing. And then we have another video in which,
no woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights. or WHO Seva, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Seva toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Seva has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Seva is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So, like I said earlier, these videos which we saw were also part of the Saver toolkit. And we are doing in this module to some expect, the epidemiology, that is when we are being informed and we are being equipped by methods. But the Engage, in Engage, we discussed, there was this case in Hyderabad, the couple, young girl and boy, they didn't tell their parents. They went for MTP to a shady place, and there the girl bled so much that she almost died. So that this kind of, and then there was so much in media, doctor killed the girl, and so much more. So all this is discussed so that our bias are changed. When we discuss with people, we know, that there are more to just what we listen and what we feel about our norms and what we feel is stigma. When we discuss with others, we change our views, we become more empathetic to the patient. So, and in the other, in which, we play the games in which a simple statement is made that it is the duty of the female to get contraception for herself. And this is discussed, and then we have views, pro and against it, and then we come to a conclusion. So this Saver module is good, and but it is a very extensive module. It takes a lot of time. If everybody wants to be trained, it will be coming up. So now what have we moved from? We have moved from unsafe abortion to safe abortion in 2000, and now respectful abortion care. And I would just like to, and these are some games, which you can play yourself if you want. And there's some questions I would ask, and I would want you to reply in the chat box. According to WHO, the access to abortion reduces the number of unsafe abortion. Can we have anything is there, Monica? Can you see any answers, true or false?
Yeah, mostly people are replying yes, true, true, true. True, true, true.
Is false. We are not saying that by providing safe abortion is only that it is done in a proper place by a proper person and by appropriate method. But it'll like if we provide Monica, can this whole thing be seen? Because I can't see the full question. Can you read it?
Yes,
According to
ma'am.
the World Health
According to
Organization.
WHO, restricting access reduces the number of unsafe abortion.
So restricting access, how will it reduce number of unsafe abortion? If you restrict, it will increase. Because we are restricting, so more and more people will go to places which are, not recognized. So the MTP amendment requires a minor less than 18 year to get written consent from parents and guardian before she can undergo termination of pregnancy.
There are mixed responses, true, false, true.
It means we've not been able to put it across that parents and guardians' consent is not required. Anybody who is above 18 is accompanying the girl can give the consent. Why the slide has stopped?
Just click on the slide again.
And of course, we have in detail talked about POXO Act, so we need not repeat it. Then a 30-year-old woman recently wants to get an MTP at 22 weeks. As a provider, it is your responsible to counsel. What is there? I'm responsibility to. आगे क्या है मनीका?
To tell her to continue this pregnancy.
Yeah. Yeah. So I think
now the answer
is correct that everybody says no, it is not.
False.
It is her own wish. And so in India, abortion is legal. We have to make it safe and respectful. That is all, which is our duty. With this, we end this Savor module. And the most important part of the today's training is that what after the abortion, and that would be taken by Dr. Monica. Monica, I will stop sharing.
Yes, ma'am. Thank you. Are the slides visible?
Yes.
Okay. So good evening once again to all of you. And since now you are apprised about the new act and basic about respectful abortion care, and of course the methods available to approach that. Now comes the significant part, which is the pre and post abortion family planning counseling and leveraging technology for referrals and online consultation. So as we all know, we've been talking about respectful care, and it should be like non-judgmental, which was a very, very important thing for all of us to learn. And in fact, during our training also, there were a few things which were real eye openers for us as well. And thus we intend to propagate them further. So counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. So mind you, each and every word and phrase in this sentence is actually self-explanatory and very, very pertinent to the concept of counseling, to the concept of communication, to the concept of reaching out to a person who's seeking abortion. I would again request everybody to please mute themselves. Dr. Anju Kumari. Yes. So counseling is very, very important whenever a patient, for that matter, for any other procedure, a patient is approaching you, as has been age-old saying that counseling is very important. Same goes for respectful abortion care as well. So pre and post abortion counseling is actually, as I said, integral part of comprehensive abortion services. It is as important as the procedure. We must not forget that. And women may need help in decision making, maybe prior to adopting the procedure, maybe just before the procedure, or any time. So it's a continuous process, and whenever needed, the spouse should also be counseled. This is when the spouse is interested, he approaches us with the patient, or otherwise if the couple is actually seeking abortion care from us. Now, pre-procedure counseling has a very critical role, and it is encompassed in the following 4 steps. You are helping the woman decide about the termination of pregnancy. See, whenever a person is approaching us, she may not be very clear about the concept of termination, and maybe while talking things out with you, she may actually decide or maybe not decide about termination of pregnancy. So giving a clear-cut picture of for the things she has approached you for, what exactly she should be knowing about the procedure, the post-procedure care, and everything what you need to tell her should be absolute, open and precise, so that she can decide upon the correct method available. And again, as we said, it's her choice to decide about the MTP. Then you are helping the woman to choose the method of termination amongst the beautiful, the basket presented by Dr. Shivani. Everything needs to be told to the woman, and she has the right to choose from that. We are ensuring the delivery of complete information about the procedure, which I have already said. And we are again helping the woman to adopt a contraceptive method. Now, this is very important. Having just the abortion done is not the complete care. We really need to tell her the contraceptive methods available right before providing her the procedure, because she needs to understand that approaching for abortion is not a method of contraception, as we have previously also reiterated. See, abortion is not a method of contraception. She needs to understand that for whatever reason, for this particular pregnancy, she's approaching for abortion, doesn't mean that this will become a kind of regular event just to prevent pregnancy. So preventing pregnancy and getting termination of pregnancy are 2 important different entities. We need to understand that and make the patient also understand the same thing. So pre-procedure counseling, now coming to the actual procedure. We have ensured privacy and confidentiality. This we have already seen in the beautiful deliberation in the first module. Then we are being non-judgmental and sensitive, very important. Establishing rapport and following a simple language, allowing the woman to clarify all her doubts regarding the procedure. And if she has made up her mind for termination of her pregnancy, she can assess her, we then assess her for the procedure in toto, so that the procedure is medically safe and sound as well. Now, relevance of peri-abortion family planning counseling encompasses quick return. What all we need to tell her in that counseling is, there is a quick return of fertility, which we all know. Opportune time for contraceptive acceptance. We should understand that this is the time patient is maybe motivated, vulnerable, or like we all say for postpartum IUCD counseling, that at that time and during the antenatal time, she is well receptive. So we should find this as an opportune time for contraceptive acceptance. Then minimum 6 months gap should be advised and counseled before the next pregnancy. And there should be health benefits and better future pregnancy outcomes. This need to be told to her following the procedure. And we must tell, and we all should understand, that 90% of abortion related maternal mortality can be prevented by ensuring contraception after the abortion. Pre-abortion family planning counseling, when to start? So as I said, first visit or consultation whenever the patient is approaching us is the appropriate time. Exception, maybe, delay can be there when, she's undergoing some kind of grief or, when it was kind of unexpected, say in missed abortion or incomplete abortion or things like that, when she actually was not wanting the pregnancy to get terminated. So what to counsel? Importance of return of fertility, which is quite quick, 10 days to 4 weeks. We are helping her with the choices available, method specific counseling, and high risk behavior wherever applicable. So if the woman is not willing for any contraceptive method, please do not refuse MTP. This is very important. Amongst the new guidelines, it's like, which is a common thing in our family planning clinics, is we get judgmental and then we say, okay, you can go, and MTP will not be done because you're not opting any method, things like that. So that has to be taken care of, should be very clear enough in your counseling, and that is the importance of counseling, that the patient should be able to willingly accept the method. But if she is not willing, please do not refuse MTP. Try and counsel her after the procedure again. If she is still not willing, call her for follow-up in a week's time and then again counsel. So much is the importance of counseling and talking and communication with your patient. Assessing suitability for post-abortion contraception, general guiding rules are: abortion process is complete, no existing infection, no injury to genital organs, and chances of fresh pregnancy ruled out. Post-procedure, again, it has a critical role. It ensures the woman has understood precautions and care needed during the post-abortion period. It is an opportunity to counsel for contraception again in case if she has not previously accepted any of your provided choices. And you're again reinforcing the need for continuing the use of contraceptive method chosen. So it should not be like a short-term thing, like, okay, abhi procedure hua hai, you are vulnerable, accept it, she accepts it, and then kyunki doctor sahab ne kaha chalo abhi le lete hain, baad mein I'll leave it and all. But your counseling should be such that it reinforces, and post-procedure you are again making sure to tell her all the beneficial part of the contraceptive method chosen and for its continuation. What's the actual procedure post-procedure? Is continue, reassure, repeat. Like, continue to ensure privacy and confidentiality, reassure her in case of any problems she faces, and repeat the information about post-procedure care and danger signs. Now, if she's already opted any particular family planning method, please appreciate her step taken, and immediate care should be provided for things like IUCD and MPA process. Then ongoing should be oral pills, follow-up protocol should be told, continuity of reproductive intuition, and various cards can be maintained and shown. But if she is undecided, you have to allay her anxiety. There is importance of immediate adoption and choosing the method, extended period of adoption, couple counseling, and EC pills, of course, are anyways there, but still you need to tell her to adopt a more constant and continuing method of contraception. So what are the choices available and what to tell them about that? Post-abortion contraceptive methods, when we talk about barriers, that is the condoms. When the timing of the abortion is first trimester, we can advise that as soon as the sexual activity is resumed. And if it is after second trimester abortion, again, we can tell them that as soon as sexual activity is resumed, this method can be adopted. And what additionally we can tell them, we all know it has no hormonal side effects. It can be used without consulting a health provider, easily available. Additional advantages of preventing STIs and HIV infection, enables men to take responsibility of contraception. So wherever we find an opportunity for the understanding partner to take the lead, maybe this method will be helpful. Then when it comes down to IUCDs like 380A or 375, IUCD 370, copper 375, then after first trimester abortion, it is inserted immediately or up to 12 days after confirmation of complete abortion using a surgical method. When we are adopting medical method, it is inserted around day 15 of the process, provided complete POC expulsion is confirmed and risk or presence of infection or any other contraindication is ruled out. We all know that. When it is after a second trimester abortion, it can be inserted immediately or up to 12 days after the procedure is complete and contraindications ruled out. Additional information, of course, we know long-term protection is there with IUCD 375 5 years and 380 10 years. It can be provided by trained doctors, A&M nurses, and only trained doctors after medical abortion, and by PP-IUCD trained doctors after second trimester abortion. No interference with sex, that needs to be told to them. That is again an important part of counseling. And there is immediate return to fertility on removal with no hormonal side effects. Coming to combined oral contraceptives, immediately or up to 7 days after first trimester abortion, using surgical method. And whenever a medical method has been used, it can be started on day 3 with the dose of Misoprostol or within 15 days of the process after confirmation of complete abortion. So very importantly, you have seen that after medical abortion, the contraception is started slightly late than the surgical abortion. And after second trimester abortion, it is immediately or up to 7 days after abortion. Additional information, regulates menstrual cycle, can be provided by all health workers after first screening by a trained provider. No interference with sex again. Offer protection against ectopic pregnancy, endometrial and ovarian carcinoma, and benign diseases such as fibrocystic and fibroadenosis. It is not suitable for women who are breastfeeding babies, who have breastfeeding babies less than 6 months old. This is a very important point. For long-term injectables like medroxyprogesterone acetate injection, first trimester immediately or up to 7 days. And for medical, it can be started on day 3 with the dose of Misoprostol. In cases of second trimester, it is immediately or up to 7 days after abortion. Now here we must remember that opposite to contrary beliefs, as such, it has no effect on quality and quantity of breast milk, and there are no estrogenic side effects. It offers protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroids. And of course, who can provide it? There should be doctors, which can be MBBS, Ayush worker, A&M, nurses, after screening by doctors for the first injection. And of course, it is highly effective. As regards permanent method, of course, here comes, counseling is actually very important in these cases, because for a couple to adopt a permanent method is actually an important thing. For female sterilization, it can be performed after the abortion in absence of any infection or severe blood loss, concurrently or up to 7 days, in cases of mini lap and lap sterilization. And with medical abortion, it can be done only after the first menstrual cycle. This is to be looked about. And in mini lap, mini lap can be performed concurrently or up to 7 days after a second trimester abortion in absence of any infection or severe blood loss. Lap sterilization is not, mind you, is not recommended after second trimester abortions. What additional information needs to be given is that it is a permanent method. We all know, of course, it's highly effective, and it is effective immediately. No interference with sex, no effect on breastfeeding, no long-term side effects, and offers protection against ovarian cancer. For vasectomy, which is one of the very important methods which males can adopt. And again, I said, as whenever male wants to take the lead, one is barrier and the other one is vasectomy, which needs to be offered to them. Independent of the timing and procedure of abortion, especially in cases where female is probably not medically fit to undergo any other surgical procedure of contraceptive method. So in that cases, vasectomy should be emphasized. And very effective permanent method of contraception, no interference with sex, no long-term health risks. Couple must use another method for 3 months, as we already know. Contraceptive methods with medical abortion, as I've already said, this is in a nutshell, the graphic presentation of when to start that. Again, for vacuum, after vacuum aspiration, combined oral contraceptives can be given within 7 days, injectables within 7 days, centromin within 7 days, IUCD anytime till 12 days, and tubal ligation, of course, can be done immediately after vacuum aspiration. Regarding teleconsultation and other technology in the current times, especially the COVID times, has taught us a lot about this telemedicine. So what about that? When we are leveraging technology and we are providing services through online consultation, these are the methods, but we should still remember that counseling can still be done in teleservices. So teleconsultation, telecounseling, teleguidance, telereference, telelinkage, any kind of service which as such we are providing face-to-face, especially the talking, the communication and counseling part can very well be done online as well. And in that case, it is known as teleconsultation or telecounseling. Of course, information, education, counseling, IEC, which we otherwise provide through pamphlets, through media, through face-to-face conversation. There is the use of technology as well, and we call that techno IEC. And these are a few examples. There has been a very popular program, Ask Tanu, in the social media, which has taken lead in providing counseling services. Various YouTube videos are available to clear your doubts. Then there's a website, Hamdo, infographics, helpline, patient education platforms, and this particular training program, which we are conducting by the help of WHO, is one such education platform, and this will go a long way, reaching out to many, and then eventually all the information reaching out to the grassroots level as well. When we do the SWOT analysis of teleconsultation, the strengths, of course, as I said, COVID era, see, SWOT is strength, weakness, opportunity, and threats. And strength being COVID era, approachable throughout the process, confidence building, awareness, you spread out the question and answered at ease. Weakness would be, of course, there's no face-to-face consultation as such, and you cannot, that effectively demonstrate a particular thing which would have been otherwise possible in a face-to-face consultation. Opportunity, of course, privacy and comfort. There's a communication is anyways one-to-one, but privacy can be maintained. Cost saving and number of visits can be cut down. Threat, of course, you miss an opportunity to actually meet the patient, and at times things can be misdiagnosed due to maybe a faulty communication online. Applicability of components of comprehensive abortion care, assessment, counseling, and follow-up. Very important. When we are assessing the patient, we are confirming the diagnosis and the contraceptive need of the patient. Counseling can be done through video conferencing or Zoom in the online services, and follow-up may be hybrid. You can do an online follow-up as well, but at least one visit and follow-up would definitely be required. And in medical abortion method, recommended is actually 3 visits, and that needs to be prior told to the patient. So the key messages which we wanted to convey to all is that we need to really realize the need of post-abortion family planning counseling and the services being provided. We are bringing the couple on board, and we are actually striving for 100% coverage as responsible obstetrician and gynecologists, and capitalize on the basket and applicability of post-abortion period. Technology, as far as possible, we all have become tech savvy in one way or the other. So the scope for entry of technology in comprehensive abortion services is important. And concern would be policy making, malpractices, service costs, and access, so to say, which goes on for any such kind of service being provided online. And adolescent reproductive health needs both online and offline service provision. So thank you. And I would once again reiterate, as ma'am has already told you twice earlier, that you really need to fill the post-test before leaving the meeting, and a certificate from FOXI WHO will be provided only after the completion of post-test and feedback. Thank you all.
And I saw so many messages saying that more such training should be done. So we have one PPIUCD training for private practitioners. So any private practitioner who's interested can apply to AOGD. We have 2 online sessions, and then they get the opportunity to come to a hospital, maybe Safdarjung or some other hospital nearby. There they are given hand-on training in PPIUCD. So those interested and who are in PPIUCD, this is in collaboration with Foxy, Government of India and AOGD. Okay, now I think leave के बाद आएगा ना option, Monica, उसका?
leave, पहले leave करना है, फिर pop-up आएगा.
So all of you can leave. A pop-up will come in which you have to write, continue, and fill up the post-test.
Madam, sorry to interrupt you. This is Shriman, madam. I'm sharing a link in the chat box also. You can copy and you can send the post-test and the feedback also, madam.
Okay, so where is the link in the chat box?
Oh, no, I'm
there
sending
been,
now.
Dr. Achla?
Yeah.
Before we leave, there were just 2 important questions which were left. Can I just ask
Yeah,
that
yeah,
to
please.
you? So when we are asking for a permission from board, is there any specific procedure to get the permission?
No, all the patients' data, reports, finding, they have to be taken to the board. The doctor for whom the patient comes, she is more than 24 weeks. So she first makes her own diagnosis, collects all the data, the reports, whatever imaging is required, and then she has to apply, the patient has to apply to a board which doctor will guide us. At the moment, I know of only one board which is there in Molana, LNJP, though AIMS also is supposed to have one, but still we are not very clear about the boards. And then the board would be constituted, and then it may be constituted from the doctors of the same hospital from which the request has gone, which is suggestive, and it at least should have a sonologist, a pediatrician, and a gynecologist. And it is suggested that the board should have a woman, and the HOD of the institute possibly should be the chairperson. So does that answer that question?
All. Yeah, I think so. And I guess these were all the queries. And probably one short question to you, Dr. Shivani. How early can we give MTP pills? Even if the patient is just 2 days overdue, can she approach you for a medical method?
Actually, I think there are no guidelines as far as the lower limit is concerned, but yes, we generally don't give in 2 days overdue. I think at least she should be 6 weeks or so.
So that we have this within 72 hours, pills which can be given.
Emergency contraception can be available to them.
But that is not a method of MTP, it is considered a method of contraception. Those who want to apply for PPIUCD program can just ring up the AOGD number or write on the mail, or they can directly WhatsApp me that they want to do the training. Once a group of at least 10 is made, we will do the training because it is hands-on, so we don't want very booked groups. So we have already completed for 15 people and they are doing their hands-on now. So next we can do the online training, and then after these 15 people finish, they can come and do the on-site training. So kindly leave and in the pop-up continue and fill up the post-test form. Okay, the post-test.
Ma'am, it was already there in the chat box, so I have filled it and submitted the feedback.
Good, good.
Madam, this is Shriman. I posted in the group, madam, chat box.
Okay, it was there in the chat box. Yeah.
Good. So whichever way you do it, you have to do it, and then you can exit.
Right. Ma'am, that PPIUCD, like I'll be interested for that.
Yeah, so you can write or send me a WhatsApp or ring up in the AOGD number and we'll put your name. And once we have 10 people, we will do the training.
Okay. Thank you, ma'am. Thank you. Anyway, thank you, ma'am. Very amazing and very, nice this thing session. We'll, definitely try to tell all other gynecologists also and other even, I think, staffs also, service providers to, join this program. Thank you.
Okay,
Have you posted the questionnaire post session?
Yes. I have posted the questionnaire, even the feedback.
I can't see the link for questionnaire.
Bashir, can you put the again? Put it again. Somebody said
I
they can't
sent
see
it recently only, madam, at 5:44. Okay, then I'll send it again.
Somebody has asked those who have been raped, do they need to give legal proof? No. They don't have to give legal proof, but once a patient with the rape comes, you have to inform police. They may or may not make an FIR, but the police has to be informed. So should we close the program, Bashir, or people are still doing the post-test?
And this is Shriman, madam. They can
Okay,
copy the
Shriman.
link and they can leave the meeting, madam.
No, what about us?
Yeah, ma'am, you can.
Yeah.
Thank you, ma'am.
Will we get the link of this program, ma'am? Can we ask him? Ma'am?
Okay, we'll ask him. We'll ask Shriman. Dr.
Yes, ma'am.
Shivani is asking what we have done. Can we get the YouTube link like we got for the previous programs?
Yes, ma'am. Yes, ma'am. I'll send it, ma'am.
When will it be available?
I'll send you, ma'am. I'll send you in some time. Like, after the meeting, I'll send you.
Okay.
Okay.
Thank you, ma'am. Thank you, ma'am.
Thank you.
Welcome, ma'am.
Thank you, everybody.
Thank you, everybody, for
Thank you,
joining.
Shriman.
And tell more people to, write to us if they want to do training. Then we can take another date for training. For this, we need at least 100 people, registered before we can take a date.
Thank you, ma'am, for such a wonderful training program, ma'am.
You're welcome. And you can join the PPIUCD also.
Yes, ma'am. Even I am thinking of joining that. I'll give my name for that to you, ma'am.
Yeah.
And ma'am, you are such a wonderful teacher, ma'am. I mean, इतना अच्छा लगा मैम आपके आज सुन के ना, मतलब मैंने फर्स्ट टाइम आपको मतलब लाइक एज ए टीचर की तरह सुना एंड इट वाज पार एक्सीलेंस मैम.
I know, मैं सारा टाइम चीफ गेस्ट ही होती हूँ ना.
Yes, ma'am. Yes, ma'am.
I'm Sharda Rai from Kolkata. This is the first time I've attended. It was a wonderful learning experience. And I would also like to join your next PPIUCD too.
But how will you do the on-site part of it? You are in Calcutta. It is both on-site and off-site. So it will come to Calcutta also. Then you can, because it's going all over India. So when it comes to Calcutta, then you can join.
Thanks, Achna ma'am. It was very nice. Enjoyed it and we learned so much.
Thank you, Shama.
Ma'am.
आया फिर खाना बनवा लो. दाल तो बनी रही है, थोड़ी सी पल्लू के लिए हम भी वही खा लेंगे सुबह। हरी धुली मूंग की बन रही है, धुली मूंग की।
रोज कहाँ खाए?
आई नो, मैं तो दोपहर को भी मैंने वहाँ नहीं खाया, मैं तो दोपहर को भी नहीं खाया इसलिए वहाँ पे।
How will all these participants get the certificates, ma'am? They will provide this. Ma'am, आप unmute करिए, unmute.
Once their feedback form reaches them in due time, like it came to us, it will come to them also. Shriman, I'm right?
Yes, madam. Shivani, madam, I'll send you the link, madam, through WhatsApp. Check your mobile once. Shivani, madam, this is Sriman.
Yes.
Madam, I'd ask for the YouTube link, right, ma'am? I send it through WhatsApp.
To Dr. Shivani?
Yes, ma'am.
You can send to any one of us, then we'll share.
I send it to madam only, ma'am.
Okay. Great. Thank you. And Shipra is asking how to join PPIUCD session. Just WhatsApp me, send a mail to AOGD or ring up AOGD office. Your name will be written.
Yes, so ma'am, I will share it to.
Yeah, with me and Monica. Yeah.
Yes.
Not with anybody else. Yes, Shipra, you can leave if you have filled up the PPIUC. Anybody who's filled the form, they can just leave.
I have not filled the PPIUCD form. My connection.
No, not PPIUCD. The post-test form.
Okay. Post-test I have already filled.
Yeah. PPIUCD is a training. If you want to attend, you can call me or AOGD or write a mail to AOGD.
Thank you.
Those who are not able to log in, I will send them a link of another date, which is soon going to come up. I think it is 25th and 26th. They can join then. It will not be by us, but there is a training on 25th and 26th. So those who are not been able to join, I will send the link. Yes, Amita, you can join the PPIUCD training. Just WhatsApp to me or to AOGD Secretariat mail or ring up our secretary. Are you saying something, Shipra? I can't hear you. You're muted, Shipra.
Unmute yourself.
Maybe you're, yeah. Can't hear you, Shipra. No, Can't hear you. Maybe your speaker is on off this thing. Shriman, the problem is at Shipra's end or what? We are not able to hear her.
Maybe internet issue, madam, from Madam Ant.
Shipra, if you will turn off your video, maybe we'll be able to hear you. Can't hear you. We can only see your lips moving, that's all. No. Can't hear you. You can put it in chat box, whatever you are saying. Shriman, somebody is asking if they can get a recording of this session. I don't think it is allowed, is it?
Yes, ma'am.
Dr. Shipra is asking, can she get a recording? Is it allowed or not allowed?
I'll ask Ajay sir, madam. If Ajay sir said okay, then I'll share the link to madam also.
Yeah, but I don't think so as far as I, but maybe you can ask and
Yes, ma'am. Madam, can I end the meeting, ma'am?
Yeah, I think so. I think most of they can fill their form at their own convenience.
Yes, ma'am.
Yeah.
Thank you, ma'am.
Okay. Thank you. Thank you for the support.
Welcome, ma'am. Welcome, ma'am.
Thank you. Bye bye, ma'am.